Someone can hear me? How about now? Does this work? Am I a little bit louder? Yeah. Okay, awesome. Okay, so we're gonna start. Thank you for coming, everyone, and welcome to our second workshop ever. If you didn't come to the first one, which was a while ago, that's completely fine. We thank you for joining regardless. Um, our first workshop was held a few weeks ago, and all we really did was we introduced some Model United Nations basics. We introduced things like parliamentary procedure, and we compared it to other procedures in the actual UN, such as Robert's Rule of Order, and we just compared and contrasted the two. We just went over some very small basics. So if you missed that, there's a recording of us on our YouTube channel. We'll also link it in an email after this meeting for you guys to catch up on. But we just went over some small things to know about Model UN for starters. But today we're going to take a break from that. So today we are honored to have our first guest speech. We're going to have a guest speech today by none other than Sirad Hassan, who's going to talk about today's state of Somalia. She is currently a first-year PhD student at Harvard Chan School of Public Health. So please welcome and put your hands together for Sirad, and she's going to take it over from here.
Oh my gosh, thank you so much. Very happy for you guys all to be here. Okay, I kind of prepared like a couple of slides, but I feel like I'll probably be mostly talking at you guys for a good bit, and then I put together some discussion questions and wanted to give you guys at Health Model UN the space to sort of do your drill and talk about your reflections afterwards. So if you need to cut me off if I'm talking too much, please let me know. Awesome.
Let me know when to share the structure slides.
Yeah, feel free to go ahead. Cool. Okay, so today I'll be talking about from historical struggles to today's emergencies, so charting the course of public health in Somalia. Very wordy title, but basically I'm going to be talking about like the historical, geopolitical context for the situation in Somalia right now. And then towards the end, I'll be focusing on primarily the water crisis that's happening there right now, and focusing on sort of just like general reflections and what we can learn from the different frameworks in public health that will help us better understand how we can move forward and how we can create and work on interventions that put the people in Somalia at the forefront. So yeah, next slide. Great. So yeah, I think for me, it's super important to talk about positionality when talking about different public health issues. So I just wanted to flag sort of three main things, at least in the context of this talk. So I am Somali. I am the daughter of a Somali asylum seeker and a Somali refugee. And I am currently, as Yasmin mentioned, a PhD student at Harvard, specifically focusing on population health science or public health. And the department that I'm in and the sort of theories and frameworks that I'm coming from are primarily focused on social and behavioral sciences. So a lot of what I'll be talking about in the beginning will be very theory heavy. And those of you who are watching this who know me will probably have heard some of this before. But yeah, next slide. Great. Okay, so you guys are going to get a history lesson right now. I'm not sure how many of you know much about Somalia or Somalia's history, but I did want to flag sort of some important historical things as we get into the public health discussion. So as you can see on the right and also on the first slide, the title slide, I put a picture of the Somali flag, which is basically the blue background with the white star. And I wanted to sort of pull this image and pull also the image on the left about the colonial powers in Somalia and sort of like the history there, as well as sort of what the flag sort of represents in terms of that colonial history. So the history of the Somali flag is very vivid and poignant. There's a very beautiful history within Somalia, but I wanted to focus on how sort of this flag is also a symbol for unity and resistance against colonial dominance. So despite facing initial rejection from the Italian administration over perceived similarities to other flags, the striking blue field represents the sky, as you can see on the top, and the bottom represents the Somali Sea. So I just want you all to have this imagery whenever you see the Somali flag. I think a lot of what people think about when it comes to Somalia is the representations in Western media right now about piracy, aka the Somali Navy, and sort of just like the different negative illustrations that Western media has about the country. But I think it's really important to understand like the beautiful history of the country. So the white pointed star that is in the center of the Somali flag is representing the 5 different parts of Somaliland, or the Somali Greater Somalia. So that includes the British Somaliland, which is the left part, and I believe that's represented in the red on the slide. There's the Italian Somaliland, which is the green. That's the part of Somalia that my family comes from. There's French Somaliland, which actually, like, right now is Djibouti. There's the Northern Frontier District, which is what's presently like northern Kenya, and then Ethiopian Somaliland. So I don't want to spend too much time talking about like the specific history, but I did think it was important to flag. And just thinking about sort of the perpetual journey towards self-determination and unity, like, of course, history did not start with colonialism. So, a lot of what I'll be talking about and a lot of the issues that are in Somalia right now have been perpetuated by colonialism. And I'll be talking about that further in the following slides. So next slide. Cool. Okay, great. So I'm going to be talking to you guys about some of the frameworks that I am coming from in terms of thinking about public health in Somalia. So there's the ecological social or the eco-social theory framework, and it was developed by one of my professors at Harvard, Dr. Nancy Krieger. And it illustrates the complex interplay of societal and individual factors that contribute to health inequities or inequalities. And at the heart of this theory is what I think is really important, which is the concept of embodiment, which essentially refers to the way that we biologically incorporate the material and social worlds around us. So this theory emphasizes that health outcomes are not just the result of individual behaviors or genetics, but are deeply embedded in the societal and ecological context. So I know there's a lot going on that picture on the screen. So I'll try my best to sort of break it down to as simple as possible. So this framework talks about the distribution of health along many different lines. So this includes class, racial and ethnic, and gender inequalities, all of which have been further influenced by historical context and power dynamics at multiple levels. So global, national, regional, and individual. And health disparities, therefore, can be seen as the embodiment of these layered inequalities over the course of a person's life from in utero to adulthood. So the reason I bring this up, I want to apply this framework to public health in Somalia, both past and present, as it offers insights into the country's specific health challenges. So during the colonial era, Somalia experienced divisions that contributed to enduring health disparities. For instance, the different regions that were controlled by the British, French, and Italian powers that I mentioned before, each of these different colonial powers had distinct health policies and degrees of investment in the health infrastructure. So post-independence, the fragmentation caused by colonialism, coupled with political instability, has had lasting impacts on the Somali healthcare system. So the contemporary crises faced by Somalia, including poverty, conflict, and limited access to healthcare, are manifestations of both the historical and current inequalities that can be analyzed through this theory. So the unequal distribution of power and resources, ongoing conflict, and social stratification have all led to many of the significant health disparities across the Somali population today. So understanding these elements and understanding embodiment is exceptionally crucial for addressing public health concerns in Somalia. And by acknowledging the societal and ecological factors that shape health outcomes, interventions can be designed to target not just the individual behaviors or symptoms, but the underlying social determinants of health. So this comprehensive approach is extremely vital to developing public health strategies that strive for equity and the improvement of health conditions for all Somalis. Next slide. So I wanted to also pull the decolonial global health theories that I've learned about and apply that specifically to the Somali context. So the decolonial global health theories honestly mainly challenge the remnants of colonialism within global health practices. This is just like an aside, but I think from a lot of my own personal experiences in the public health space, a lot of the work that is done in international humanitarianism and a lot of the global health departments and systems that are out there have a very, for lack of a better term, white savior complex to them. So I think it's really important that we approach and understand the different historical contexts in the continent, in Africa, as well as, in individual specific countries and contexts through a decolonial lens. So there's a couple of different resources that I'm happy to send out. I don't want to spend too much time just like throwing all these different theories at you, but I think it's important to look at the different mechanisms and underlying structures that continue to perpetuate health inequities, particularly in post-colonial societies right now, like Somalia. So there's a few different toolkits, including the one that's on the screen right now, that talks about the sort of colonial remnants in global health and what it means to decolonize global health. But I think the most important things to take away and sort of thinking about interventions and strategies, and as you know, you all in Health Model UN and the different groups out there that are trying to approach these issues, it's important to address racism, anti-Blackness, and tribalism, which are intricately linked to colonialism and continue to divide societies if not confronted, and continue to worsen the health outcomes of the communities that are in these contexts. So there's a few different levels of colonial remnants in global health. So there's that which is in the daily practices, the organizational inertia, and the fundamental paradigm shift. And these just highlight that decolonizing global health is intrinsically tied to the global political economy and requires a systemic approach to remove social economic inequalities rooted in colonialism. So to bring it back to the topic now here, in public health in Somalia, it reveals that there's a profound impact of historical colonization and its persistent influence. So Somalia's past, under various colonial powers, fragmented its health systems and established inequalities that resonate to this day. And a decolonial approach would advocate for the empowerment of the various public health institutions that are Somali run in the country, respect for local priorities, and true ownership of health initiatives by the Somali people. So in this historical context, the colonial period displaced a lot of the local knowledge in Somalia and imposed foreign public health solutions, which caused a lot of issues. And this often benefited the colonizers' needs over the health of the indigenous population. So the present challenge for Somalia and other post-colonial nations in the continent is to rebuild their health systems in a way that serves their population equitably, countering the residual impacts of colonization by promoting self-determination in health practices and policies. So this approach is essential in transforming the public health in Somalia and ensuring that the country's health system is robust, sustainable, and reflective of the population's needs. Next slide. So the last framework that I'll be throwing at you guys, which I think is important context for just thinking about public health in general, so I did want to lecture a little bit about this as well, is the 4 I's of oppression. So as you see on the screen, it's ideological oppression, interpersonal, institutional, and internalized. And this framework provides a really powerful lens through which to understand and deconstruct the multiple layers at which oppression occurs. And this framework is particularly important when thinking about the public health landscape in Somalia. So, for instance, ideological oppression is essentially where the core belief lies that one group is inherently superior to another. So in the context of Somalia specifically, colonial powers instilled a hierarchy that devalued local customs and knowledge, which can persist in public health approaches that discount traditional practices or indigenous knowledge systems in favor of Western methods without contextual adaptation. And also thinking back to what I was talking about with the divisions, the artificial divisions of the Somali people throughout these different borders, that also contributes to the various ideological oppression. And also I'll touch on this a little bit too when I bring up the Somali Civil War and how that affected public health as well. So the next I, which I guess it's a little bit, my notes a little out of order, but I want to talk about the institutional oppression and how that manifests in the entrenched structures of society, such as healthcare systems, legal codes, and educational frameworks that maintain inequity. So Somalia's public health system, as we know, is influenced by many different colonial powers. And there's a lot of these biases that are still remnant in these different policies that exist in Somalia today. So it's important to think about that effect on healthcare in the country. And then there's, of course, interpersonal oppression or interpersonal racism that occurs on a personal level, where individuals enact biases and discriminatory practices that are endorsed by societal norms. So healthcare workers in Somalia, whether they be, you know, Somali people themselves or, you know, individuals who are coming in for humanitarian programs and things like that, they might enact these biases and discriminatory practices endorsed by societal norms. So health workers in Somalia might unwittingly or otherwise provide differential treatment based on, and this is important, Qabil or clan affiliations, gender or socioeconomic status, perpetuating health disparities. And then there's internalized oppression, which is the internalization of societal beliefs of inferiority by marginalized groups themselves. So in Somalia, this could translate into individuals feeling resigned to poor health outcomes. So just feeling like, okay, this is just how it is. Or just in general feeling distrustful of health interventions, potentially as a result of historical experiences of marginalization and neglect. So I bring all of this up because I think it's important to understand these four eyes of oppression, as we need to continue to reimagine what public health looks like in Somalia. So by recognizing and actively working against each of these layers of oppression, public health initiatives can be more inclusive and effective. And this multifaceted approach is essential for a public health system that not only heals, but also liberates from the change of historical and contemporary forms of oppression. So next slide. So going back to the image that I had from before, just for the amount of time that we have and sort of what is presently known as Somalia right now, I'm going to be focusing on primarily what is the former British Somaliland and Italian Somaliland. And these are the sort of, this is the part of Somalia that gained independence in 1960. June 26th, 1960 for the British, or sorry, yeah, from the British Somaliland, and then July 1st, 1960 for the Italian Somaliland. Next slide. Great. Okay, so now I'll be talking to you more specifically about the colonial historical influence in Somalia's public health. So I'll be talking about both the colonial period under British rule and Italian rule, and the tide of epidemics that came during this time period. So this includes smallpox, cholera, tuberculosis, to name a few. And these weren't just simply biological agents that were moving through these populations. They were actually carried on the backs of colonial ambitions, military movements, and there were a lot of profound social disruptions that they inflicted. So the British, while trying to weave Somaliland into the empire's fabric, inadvertently spread a lot of diseases. And the response to this was hampered by the inadequate medical infrastructure, leaving many of the interventions of this time period to merely scratch the surface of the burgeoning public health needs. But for instance, there are diseases like syphilis that had some success in terms of combating the sort of infections that were happening in this time period. But for instance, interestingly, it was not just the medical campaigns that curbed disease incidence in this time period. as the dust of conquest settled and there's a semblance of stability in the region, disease rates thankfully started to fall. And I think reflecting on this era forces us to think about how the health of this population is inextricably linked to its political and social state. And so for Somalia, this time period is woven with the threads of resilience and a poignant reminder of the indelible imprint of colonialism on public health. So the late colonial period in Somalia witnessed disease such as measles, also smallpox, relapsing fever, tuberculosis, influenza, and a few different venereal diseases that were tearing through the population. And the key to the spread in the late colonial time period was specifically the economic upheavals that were caused by the droughts in Somalia at the time. So the years that these droughts happened were 1943, 1947, 49, 1950, 1956, 1959. And this precipitated mass migrations and the growth of towns as nomads sought for better living conditions. So these shifts fostered epidemic diseases in rural areas and endemic diseases within the different towns. So I think it's important just to highlight that, you know, a lot of these diseases in this time period, like again, going back to the different frameworks that we talked about before, a lot of the different you know, disease like tuberculosis, venereal diseases, as they're becoming rooted in these urban settings, it's important to recognize that a lot of this incidence and prevalence of these diseases were also caused by the colonial influences of the time period. Well, also to say, there were some efforts done by these colonial administrations to create different public health initiatives, focusing on prevention and control. So the British and the Italian separately had their own mass treatment campaigns and the development of medical infrastructure. There were hygiene policies that targeted improving conditions in towns with sanitation services, food hygiene, regulation, and housing improvements. And then there were some rural health programs that aimed at disease control through vaccination and educational campaigns, although the effectiveness of these were often hindered by the resistance and distrust from local populations due to the suspicion of these different colonial medical practices. So it's important to recognize that there's also the political element and the severe distrust that Somalis had of these different colonial powers and how these colonial powers are oftentimes the reasons that these diseases came into the context in the first place. Next slide. All right, just a couple more slides left. So now just thinking about the impact of the 1991 Somali Civil War and how that affected public health. So as I just saw your message, Justine, since 1991, Somalia has been embroiled in a continuous civil conflict. A lot of it has been tribal conflict. A lot of it has been due to, you know, very different geopolitical and proxy wars that have happened at the time. And that I could give like a whole lecture about that separately. But I do just want to focus on how specifically how the absence of a stable government has severely impeded the development of healthcare and public services, and how the displacement of civilians and disruption of aid in this region has exacerbated health crises in the region. So the conflict has resulted in the displacement of over 1 million people, creating a large dependent population on health relief and food aid. And then in 2006, there was also a wave of renewed fighting that caused significant internal displacement, with only a fraction of the required food aid delivered due to security concerns. And the majority of humanitarian aid operations are now managed remotely due to dangerous on-the-ground situations. So the lack of government that has led to a collapse of the vital registration systems has made it actually really difficult to fully measure the full impact of the conflict. Like the epidemiology side of me is very sad about this because it's really hard to know exactly what the impact is in terms of like the exact numbers, but it is pretty obvious that given the huge wave of Somali refugees internally and out of Somalia, it's very obvious that there has been an elevated amount of crude death rate, the increased amount of deaths and under 5 death rates, which indicates severe health emergencies in particularly in the southern part of Somalia. And data since 2006 has showed mortality rates have surged above crisis thresholds, suggesting a lot of different critical health situations. And then just looking at the sort of broader public health issues, there's preventable diseases and malnutrition remaining leading causes of death, highlighting the need for fundamental public health initiatives. Immunization coverage is less than 40% for children, which also demonstrates an urgent need for comprehensive health campaigns. And successful health programs require support from local leaders, which sometimes can be difficult, and needs to also be specifically tailored to the different contexts of Somalia, as Somalia is not just one homogeneous region that you can approach. You can put one intervention that will, perfectly fit into the whole region. Like you have to think about how different provinces, different cities, different towns, different types of people will contribute, and how these different interventions can be tailored to each context. And I think that, with the different elections in Somalia has since 2009 have brought, a few different waves of hope for stabilization in the region. But despite this, to this day, just factually, like Somalia does remain fragmented with various regions under different authorities, which complicates the delivery of aid. The ongoing insecurity poses a persistent threat to humanitarian assistance, which again continues to remain complex due to the Qabil or interclan politics. And, thinking about the sort of difficulty of getting aid and humanitarian support in the region, the majority of the population does face threat to survival without sufficient aid. And the healthcare system is heavily reliant on international aid and struggles to cope with the high demand of services in the conflict and the war. So as we think about the different complex political and humanitarian landscapes that exist in the whole of Somalia and within Somalia, it's clear that, the different interventions and things that are proposed, from, a model UN perspective, but also practically in the real world, how can we make these different public health responses both adaptable, robust, and effective? So despite many of the challenges, there have been some effective campaigns, such as the different vaccination campaigns and maternal and child health programs. But again, like it's important to think about how we can, address the issues that are at hand now, and then how can we prevent further health crises. Next slide. Just 2 more slides. Okay, cool. So I know Yasmin and I have talked a bit about this before, but I also wanted to just flag right now that one of the biggest public health concerns in the region is the water crisis, which has been intensified by what is the most severe drought in the last 40 years. It's been incredibly difficult with the absence of rain in the region, and there have been deeply rooted systemic failings that have let this crisis persist and escalate. And honestly, like looking at sort of the Somali water shortage issue and update that's happening right now, it provides like a really interesting case example for, the public health issues in the country, and sort of the colonial legacies that we were talking about before. So the longstanding civil conflict has dismantled the infrastructure and systems that were meant to safeguard water policy, and there's no denying the dire need for functional water sources. And a lot of the information that I've pulled from this slide and the next slide are from the World Health Organization and from UNICEF's joint monitoring program, which reveals that astonishing 40% of the different sources that were set to sort of help Somalia with public health issues are now non-operational. And Somalia isn't exactly like a water scarce country. Like if you look at the map, like we're on the Indian Ocean, we have rivers that are within the country. However, the country suffers from poor water governance, and there's really no limited accountability or planning on the governmental level, and the civil unrest in the region only exacerbates the strain on an already fragile system. So it's important that we acknowledge the impact of the internal displacement, the overuse of groundwater resources, and the pollution that threatens the main water supply, which accounts for 80% of the nation's water. And the UNICEF surveys in the region have indicated that there have been alarming levels of fecal contamination at the source, collection, usage points, And the absence of regulation and public education on water safety means that disease spread is not just a threat, it's an ongoing and current reality. And there are almost 3 million people who are in need of urgent wash support. So families have been reporting insufficient drinking water, and access to improved sanitation facilities is incredibly important. And people, women and children, men, anyone in the region, oftentimes are undertaking dangerous journeys in search of water, exposing themselves to disease and deepening the country's poverty. And while rains, might provide temporary relief when it does come in the drought seasons, the structural problems run much deeper, and really the nation needs more than just precipitation to solve. And there are some projects and organizations that are doing some good work in this field. For example, there's an organization that I've partnered with to fundraise Sadaqah Jariyah, or like an ongoing charity project in honor of my uncle, and like building a water well, a deep water well in my uncle's name, which is one very small band-aid solution to the water crisis there. But I think when we're thinking about the different issues with the water crisis in Somalia, it's important to think about the various structural issues that exist, and thinking about solutions that are long-term and not just temporary band-aid solutions. Next slide. It's the last slide before the questions. So yeah, so I just wanted to flag this One Health program as just thinking about different ways for international relief efforts to think about approaching public health in Somalia. So for instance, obviously, as we've talked about before, like many of these international relief efforts are complicated by internal strife and challenges operating from outside the country. And oftentimes a lot of NGOs and different organizations that are trying to do work in Somalia are actually based or try to be headquartered in Nairobi, which is in neighboring Kenya. But due to the severe insecurity within Somalia's borders at times, and just thinking about with the absence of oftentimes a stable, local government, or just sort of the fluctuation, right, in terms of the stability in the region, a lot of the traditional health data systems have crumbled, and data is really important, right, in terms of understanding what is the situation now and how can we think about what interventions would be the most effective, or what are the most important pressing issues in the time. So for instance, many of the different death rates for a lot of the various chronic and infectious diseases have surged past emergency thresholds since conflict intensified in 2006. And a lot of the basic public health services have been crumbling as a result. So I wanted to pose a couple of different questions about how we can, as public health professionals, policymakers, humanitarian workers, whatever X amount of things that you want to do in your careers as you're thinking about public health, how can we ensure that we have the right data about these issues, and how can we guide our interventions to address the urgent health needs illuminated by various studies, such as the One Health study, which I'm happy to send resources about following the talk, and also just thinking about what is at stake for Somalia's future, and what are the best interventions, and what are the best ideas moving forward. And I think, just as like a parting and closing thought, that the most important people to consult are not the people from the World Health Organization or people who are coming in as outsiders into the region, but asking people who are from the region themselves, or asking people who are from local organizations within Somalia who have the most context within the region, and getting their perspective on what interventions they need, and thinking about structural ways to address those issues, and making sure that the ways that we're addressing these issues are from a decolonial framework, and thinking about how can we repair the harms from the various colonial legacies that exist in Somalia, and how that's perpetrated in the public health situation today. So yeah, that's pretty much it. The next slide is my list of discussion questions for you all, but I know I took a lot of time, so happy to leave it all to you guys in terms of how you want to go forward.
Thank you so much, Sirad. I'm like shocked that you were able to explain such a deeply rooted and complex issue clearly in like a matter of 20 minutes or so. Thank you so much. There's a lot, and I'm so glad that you have this page up with discussion questions because moving on to a drill, we'll move into like a discussion about Sirad's speech about the issue in Somalia. And I think it's nice to have these questions of consideration up here. So with that, we'll move into a discussion. I think I will refrain from screen sharing. I would normally screen share, but I'll leave this page up here. Are there any questions for Sirad before we get into like a quick like discussion, a debate drill? We'll be also having like a short 10-minute period of research and just reading up on about this issue as well. Just thinking about what to say, what to talk about. That's completely fine. We'll take 10 minutes before we start it. Were there any questions? Oh,
Thank you guys for being here.
awesome. No, thank you for being here. Okay, awesome. Great to hear. So, okay, so then I guess we'll move forward to our 10-minute period of research and reading. So I will set a timer, and once the timer is up, I'm going to immediately move us into a, let's say a 10-minute moderated caucus or a 10-minute period of discussion. We'll be talking about the discussion questions set up on the screen here. Okay, so let me set up a timer. One second. Okay, so also before I set the timer, if anyone wants like a recap, the question, the main topic for the drill would be really if we looked in the context of UN bodies, right? Like who, like UNICEF, how can they, like Sirad put it, work more closely with Somali people to recover from the aftermath of colonization, right? Especially with other issues like the lack of governance and how it's been causing like this rippling effect on Somalia. And how can we improve efforts being made so far, like the vaccine campaigns that Sirad has mentioned? And how can we better respond to issues like the water crisis, which is one of the biggest issues thus far, as Sirad put it. So that would be our main focus for the discussion, just to keep us in perspective, because there's a lot to talk about. So, okay. If there are no questions about it or to Sirad at all, we'll start the 10-minute reading period. Your time starts now, and I'll unmute once it's over. Okay, everyone. Can everyone hear me? Okay, so the 10 minutes have definitely been up. Let me show my face for a second. Okay, hi. Okay, let me share my screen. So now that the 10 minutes were up, definitely more than 10 minutes, so sorry. We can now start with the drill. So again, the drill is going to mainly focus on the UN bodies like WHO and UNICEF that are involved currently, and what efforts can they make at this current moment to not just to try to resolve the crisis in Somalia. It's very complex. It would take a lot of more deliberation to resolve it entirely, but how can we treat it sort of in this current moment? Okay, so I'm going to call into order a 10-minute moderated caucus, a 10-minute discussion time with a 30-second speaking time per person. So whoever wishes to speak would be speaking for 30 seconds. I'd put a timer and I don't have a gavel with me, unfortunately, but I will, let's say I will bang my laptop once. I don't know if you guys can hear that. I'm like knocking. Okay, yes, awesome. So I'll knock on my laptop once to signify that you have 10 seconds left. And I'll tap twice to signify that your time has elapsed. So your speaking time is over. Okay? Okay. So with that, I'm calling into order a 10-minute moderated caucus, 30-second speaking time on the Somalian crisis. All those wishing to speak at this time, you can either unmute or just mention in the chat. I can't see the chat, but I know Aya will, or you can raise your hand and we'll pick upon you. All those wishing to speak at this time, and it could be anything, not just how to resolve it, but just a discussion, just talking about it in general. For 30 seconds speaking time. So all those wishing to speak at this time, please raise your hand. All those wishing to speak. Justin, okay. Justin, you have the floor.
Okay, can you guys hear me? Okay, cool. All right, so my thoughts were that it seems like the major issue is that there's no real kind of community, in that the speaker mentioned, tribalism and the issue coming involving it's hard to kind of post one resolution or one law to kind of distribute amongst all the people. So I think although WHO and UNICEF may not be the strongest people to organize government and other political pieces, I think that the United Nations as a whole should work towards unifying the government of Somalia before they can start implementing widespread change or widespread law that could focus on a lot of the issues. Because like America and many other nations have strong health systems and can definitely assist them in strengthening their health system, but you can't do that until you have people willing to follow the health system or follow the laws of the health system.
Thank you, delegate. All those wishing to speak at this time. All those wishing to speak. There's definitely a lot of information, but it's just a discussion. It doesn't have to be about like fixing the issue.
Hi.
Amber, you have the floor.
Yeah, my name's Amber. This is my first time joining this.
Yes, that's
So I'm
okay.
not really sure the rules, I guess. But I mean, I just
Oh.
wanted to say, yeah, because like I wasn't a part of the first meeting, but I just wanted to say that I feel like there's so many different steps that could be taken with this situation. One being that for example, with the with the water situation, I feel like UNICEF and who they can like, I don't know, I mean, I don't know if they can, but maybe like distribute water, like bring water themselves and like distribute it to the people and make sure that each like community would have like a certain amount distributed each like month, let's say. I'm not sure how that would work though, but I just feel like these two organizations have so many they have so many like resources, I would say. And so they can do a lot to help this crisis in Somalia. And I'm actually like I mean I have to do more research about it, but I am interested, especially with like UNICEF. Like I'm a part of the UNICEF in my school, so I feel like we can definitely like talk about ways that we can help this ongoing crisis. But yeah, sorry, I don't really have that much to say, but I did enjoy the presentation and I feel like Sirad did a good job. So yeah, it was very impressive.
Thank you so much, Daggett. Thank you. Sirad, you raised your hand?
Yeah, I don't know if you want me to hop in or not in the
No, please. No, of course.
but I wanted to echo like or just like, uplift what I think it was Justin and Amber just said in terms of like the reflections that they offered and sort of ideas for future solutions. I think it's really like awesome to hear you guys like, reflect on what I was talking about and like what you guys know about like creating health interventions. I think specifically to Amber's point, I worry about, solutions that are this international like governing body just saying, hey, like here is like water and let's just distribute X amount of water and have the people then like, take that. I think that it's really important that when we're thinking about like interventions and thinking about the role that like the World Health Organization or UNICEF can have in the specific context that we're ensuring that we uplift the agency of like the people who live in these different communities. So, how can we have like long-term lasting solutions that will allow for people not just to have like the water in the short term of like, okay, here, like we're distributing the water for X amount of time, you have to ration it out, but like, what skills can be taught to this community or what skills does this community already have that needs to sort of be uplifted so that the people have the agency to then get the water for themselves and to have like a sustainable solution. Because I know I'm going over like the 30-second time, Yasmin, but I wanted to just like talk quickly about like I just the reason I'm a little bit hesitant about this is like thinking about the effects of like neocolonialism right now and sort of how like or just aid dependency. Like I think that is a significant issue throughout the continent. So how can we specifically empower these communities to have long-term lasting solutions and specifically with water, but also like in a lot of other issues. But I don't want to take too much time, so
No, that's all right. I'm gonna rule the 30-second speaking time dilatory and just have a 10-minute discussion. No speaker time cap or anything like that. Just feel free to say whatever you think is related to the topic, the question up on front, or replying to other people. Yeah. Amber, you have the floor.
Hi. Yeah, I just wanted to say I agree with what Siraj is saying. Thinking about it, because you're right, you don't want them to have sort of an aid dependency on it, especially you do want them to form their own independence and like as in like be able to do this without their help, if that makes sense. So I guess another thing I would say, like a replacement for what I said maybe would be instead of them distributing it, maybe like establishing certain areas where it's like they can offer those types of resources, and at the same time they could teach the citizens how to like, for example, like maybe like how just like different I can't really sorry I can't really think right now, but it just came to my mind that because I'm like I have taking a public health class right now, like an intro class, and we talked about the 10 essential services and then one of them being that you're guaranteeing that there's equitable access for everybody. So kind of establishing like these organizations can establish kind of places where, oh, like people know that if you go there, they can like maybe like teach them how to do certain things and also offer resources. But at the same time, it's like it's not something where they have to be there in order for the people to thrive. The people could thrive without them, but it's more like they're just aiding them. Because like you said, which is a really good point, you don't want aid dependency. Because like yeah, I'm from Ghana. I'm from like my family is, so yeah, I understand like with the colonialism that like my country has faced as well. Um, it's definitely like they don't want it's just you don't want those people who once ruled over you to kind of come back and like kind of have this like savior complex where it's like, oh, like yeah, like it's like, oh, like they're the ones that know how to fix everything, which is not the case. Like we also have the same capabilities, but it's just that we need to close the gap on that inequality and access so that we can better help ourselves and like our people thrive. So yeah, I just want to say that. Sorry. I kind of went over, but yeah.
No, don't be sorry at all. We welcome discussion. Is there anyone wishing to speak? Justin, you've been recognized.
I just wanted to add one thing. So pretty much what we're saying, correct me if I'm wrong, is like that old adage where it's like you give a man a fish, you feed him for a day, but you teach the man to fish and you feed him for life. That's kind of what you're saying. Question mark. That's what I'm guessing. Or that's my like very rapid summary, if that makes sense.
Sirad, you can take that right of reply, I suppose. Yeah. Go for it.
Yeah. Yes and no, Justin. At least I'll speak for myself. Like I definitely had that saying in mind. Like, it's important that we teach people, you know, like we make sure that like you don't just give like the food to someone, like the saying. But I think that what I also was trying to get at is like, you know, why is it that we look at like these Western bodies as like they have all of this intelligence that they then have to like impart on these like communities? Like I think a lot of this knowledge is already within the community, but they like these communities need the space and stability to then be able to have that agency to then use like the skills that they already have within their culture, their tribes, whatever it might be, to then create these public health solutions. And I think there's obviously like a lot of knowledge to be gained from different communities and things like that, but I think I specifically want to question like why is it that we like always are like, oh, like this Western body, like XYZ like institution, or the US, or whatever country you can think of as like a Western, quote unquote Western power. Why is it that they have to be the ones to teach these like other communities? And I think I just want to like just like add to the discussion that like I think we need to think about like why is it that we're looking at it from that lens? Like I think there's a lot of knowledge that already exists in these communities. So how do we uplift that? And I think, Justin, what you had said before was really great, like in your initial comment, because like how can we, ensure that there's stability in this region and work with like the different local communities that are there to then figure out like what are the ways within the context in the present period can we help them establish stability and peace and work on the different improving different health outcomes and thinking about like the sustainable development goals. I think it was like the 2031 that the UN has right now. So how can we have these goals in mind, right, that the international community recognizes, and have that framework in mind, but at the same time allow for these different communities to then have like the agency and use their already existing knowledge to then have these improved public health outcomes. And I think I just like I'm always gonna be the person who's like, why is it that we're always looking to these like Western bodies? Like I think that we need to think about the ways that we utilize like these institutions like the World Health Organization and UNICEF to like be avenues to like, you know, implement and like address like these different or create these different interventions, but they shouldn't be like the like the only framework or the only institutions that are doing this work. I think that this work has to not just be done by the World Health Organization and UNICEF, but like in partnership with local communities, local organizations, and you know, uplifting that first and foremost, and then allowing for the resources of these like external organizations to then empower those local efforts. I think that was like the main thing that I was getting at. But it is sort of that point of like, yeah, like we need to make sure the long-term solutions there to ensure that people aren't going hungry, people have clean water, people are getting the vaccines they need, people are not dying from infectious diseases, and you know, decreasing the burden of chronic diseases. Yeah, sorry.
No, don't say sorry at all. Again, we welcome this discussion. There's a lot to unpack from what was just spoken about. So it's great that we're trying to touch up on a little bit of everything. And we were just introduced to this topic. So it's awesome that we have some discussion, if at all. Is there anyone who wishes to speak as well? We can take 2 more speakers, and then the 10 minutes should be up by then. All those wishing to speak.
Yeah, I just want to add one last thing. Sirad, I feel like am I saying it right? Sirad, okay. Yeah, I feel like you're very well spoken on this, and I really appreciate it because you don't see many people speaking on such crisis, especially with the education and like platform that you have. So I just wanted to say that I really respect your work and all that you're doing. And I also wanted to say, and with regards to UNICEF, I feel like UNICEF is a little more restricted, as in, well, because like since it's like a children based, so I feel like for UNICEF, they they can't, like, I'm just trying to figure out how they can help in this case because it's more like based on children, and although children are like important at the same time, um, what can they really teach them, or like, yeah, like basically I guess I'm asking a question, like how do you guys think that UNICEF can help in this case, like in terms of like children, like besides just handing them supplies, like how can they actually help the community grow in regards to children? Because I'm just confused on that part, if that makes sense. Unless I'm just boxing them too close together with children and they actually branch out and like help adults as well. But yeah, that's just kind of my question, I guess. Yeah.
Thank you for your question, Delegate. If anyone wanted to take the final speech, we could end it off on that note, and then that's it. All those wishing to speak. At this time. If not, Sirad, you got it.
Yeah, I wanted to quickly say thank you, Amber. That was very sweet of you to say that. And I hope that everyone feels encouraged to reach out. I'll drop my email in the chat in terms of, you know, if you want to talk about what it means to get like a PhD in public health and things like that. But I did want to talk about quickly the point you brought up, Amber, about UNICEF. I think that like everything you said, like I second that. And I think that some of the things that I know about UNICEF are also like within that like framework of like, oh, they only do work with children. But I was doing some, like as you were talking, like I was looking quickly at the UNICEF page for Somalia, and I can quickly drop that in the chat. It looks like there have been working with a lot of different national like NGOs, and they do a lot of services, you know, yes, focused on children, but it looks like they're tackling a variety of different issues in terms of child protection, peace building and development, health, nutrition, so on and so forth. So I think like while there is like a vast, like there's a diversity of like services and policies and things that the UNICEF organization is pushing for, I think the primary framework or the primary like lens that they're looking at is like how can we focus on children to ensure that children have good health outcomes like moving forward after either while they're internally displaced, while they're existing in the country that they live in, as refugees, as asylum seekers, as citizens of other countries. So like what does it mean to sort of support like children in that stage? And I think at least from what I've understood from my public health teaching is that it's really important to have like a life course perspective of, thinking about, okay, how you create and address like how you create interventions and address issues for children will like impact those children for life. So I think it's important that there's an organization that is specifically focused on children because and I could get into a whole thing about like life course perspective and how, like what I was saying before about embodiment and the different like, specifics within like the eco-social theory that I talked about before. But I think it's incredibly important to recognize that like children, like focusing on children is so important. And I think that like there's different needs that children have compared to adults. So like I agree, like I think, it is like limiting that it's like just children, but I think there's also merit to that as well. And I think that's also probably why, and I'm not too familiar with like the health model UN structure, Yasmin. But I think that's probably why like you guys have like those different committees and different subgroups and things like that. Like whenever you do have like a model I did model UN like when I was in high school. So I remember like the different groups and things that we would all be a part of, like the security group and things like that. So I think having something that like focused specifically like on children and like their unique health needs, and then also something that focuses on women and like their unique health needs or like different minority groups and thinking about how to uplift the needs there is incredibly important. So that's my very long-winded response to that, Amber.
Thank you so, so much. Those were amazing final sentiments. And I think just to echo on that a little bit, I feel like this topic gives so much room for more discussion. And if everyone would want it, maybe we could continue this discussion to next week when we have another debate drill. We could continue this discussion. Unfortunately, I think Sirad won't be with us, but we can still be able to continue this topic with more time to research it. And Sirad was very generous in like giving us a lot of resources and discussion questions to think about. So if we perhaps give it a week to look into it, if we really want to, we could continue this discussion to next workshop. And yeah, there are a lot of things to discuss, like WHO and UNICEF and how they differ. How can they target different issues, but try to work towards the same goal? And all sorts of things. How can we improve what we already have going on so far? All these campaigns going on at this current moment. How can we improve those? And how can we get the UN and Somali people to work more closely together? And how can we hold like colonizing powers more accountable for their history, right? How can it can't just be the UN, right? Pushing for things. The UN, again, I think we mentioned this last week, but remember that the UN is not a parliament, right? The UN can only push for recommendations and can advise for other powers to do things for certain crises around the world, but we can't. The UN can't enforce those recommendations, right? But at MAL UN we can pretend to. At MAL UN we can pretend to be a parliament and to enforce those recommendations and laws, I suppose. So we can definitely take this to next week. Thank you so, so much. That was an awesome discussion. Oh, we did this already? Just move in. Okay, so did anyone have any questions after that entire moderator caucus period for Sirad or for anyone?
Yeah, I have a question.
Yeah, of course.
This is more just about the club. So
Yes.
is this based in Princeton? Like the club is based in Princeton?
No, okay. So so for anyone else who's new, So HealthMUN is an international nonprofit. We're separate. We're not affiliated with any university or school. We're pretty much intercollegiate. There are a lot of other students from other schools who are here as members, or hopefully in the future as faculty as well, that can be allowed. But we're not affiliated with any school in particular. We're just a separate nonprofit. We push education on these healthcare issues across the world. And this was our first amazing speech by Sirad about healthcare in Somalia. So we want to take things like that per workshop for everyone and anyone, not just Rutgers students or Princeton students, for anybody. Yes. We have a very big Rutgers population right now, but that's probably because a lot of staff is Rutgers, but we are trying our best to outreach to other schools, other universities, get more diversity. But yes, we're a separate nonprofit and international. So hopefully we can get some international people here too at some point. Yeah. Yes. Were there any questions about what HealthMUN was? I know you said this is your first workshop you joined, Amber, so feel free to ask me anything. I get that it can be a little confusing. Yes. We also record all of our workshops. So we recorded the last one. And if you want to watch that, I'll post the link to it in the group me and you can watch it. It's on our YouTube channel. Yes. Were there any other questions?
Okay, thank you.
Okay. So with that, this workshop has concluded. Thank you so much to Sirad. Thank you so much to everyone who had such a great discussion about it. There was definitely a lot of questions to consider. And I think that just begs for more information to delve into and more research. For next workshop, for next week, we're going to try to talk a little bit more about the Model UN aspect of things and how we can make that discussion more Model UN-like. Like today, we were doing it pretty informally where we were just having an open discussion, no speaker time, just saying our thoughts. So for next week, we'll try to take this topic, but make it more Model UN-like. I'm going to introduce terms like moderated caucuses. What do I mean by that? What's a moderated caucus? I touched on it a little bit last week, but I'm going to get into it more next week. And then we'll, just like moderated caucuses, get into unmoderated caucuses. We'll also talk about points and motions. What did I mean when I say I motioned for a 10-minute moderated caucus? And what is the extent to what you can do as a delegate, and what do motions and points really do in discussion in Model UN? Just a bunch of terms that we're going to go through and burn through next week. But yeah, so excited to see you guys then. Thank you so much. Take care, everybody. Thank you so much.
Thank you. Good night.
Thank you.
Good night.
Good
Thank
night.
you.
See you guys next week. Yay. Oh my God. Yay. Oh my God, girl, you slayed. Girl, you were amazing. Oh my God.
Thank
Oh
you
yeah,
guys
stop
so
recording
much.
really quick, sorry. Yes. Oh my God, yes. Oh man. Yeah, I love this so much. This is awesome. I'm so glad we recorded this too, because I rewatched this again.
Oh, no, that's
for all
awesome.
personal purposes. Yeah, no, thank you so much.
I
can't
want
believe
to, no, go
you-
ahead.
I can't believe the presentation seems like you like prepped it like a week in advance. Like I I was like, what? Oh my God, no way. Oh, so sorry. I gotta stop sharing. Sorry. Sorry. Rishik was like, oh my God, I can't find my thing. Okay, cool. Yay.
No, I was gonna say stop recording as well because this is gonna be sent to
Oh,
YouTube,
I
right?
am
So
crazy. Oh,
yeah.
cool. I got you. Let me just